now I'll be handing over to Dr. Aima to take us through the first aspect of the didactic section. Thank you so much. Dr. Aima, over to you.
Thank you, Dr. Michael, for the wonderful, kind introduction. Good evening, everyone. My name is Aima Luhi Adebo Uwagboy, as he has said, and I will be taking the first part of the presentation. I trust I'm clear, right? The network is clear. I'll be taking the first part of the presentation, the pathophysiology. Awesome, thank you. So I'll be taking the first part of the presentation, pathophysiology, risk factors, and then onto the diagnostic criteria, and then I'll hand over to my colleague, Dr. Fagbemi. Yeah, next slide. Next slide, please. Yes, according to the Royal College of Obstetrics and Gynecologists, preeclampsia is a multisystemic disorder that usually arises after 20 weeks of gestation and is accompanied by one or more features of maternal organ dysfunction and or uteroplacental dysfunction with or without proteinuria. Next slide. So hypertensive disorders of pregnancy complicates about 5 to 10% of pregnancies. In Nigeria, the prevalence is as high as 2 to 16%. And preeclampsia affects 2 to 8% of pregnancies overall, worldwide. The burden is disproportionately high, like I said, in low to middle income countries such as Nigeria, where, we find as high as 2 to 16% prevalence of preeclampsia. It remains one of the leading causes of causes of maternal mortality in sub-Saharan Africa. And I believe that's why, the topic is important enough for us to be here today. It leads to us delivering our babies early, the babies coming early, and sometimes, 25% of all low birth weight infants and a good number of preterm births are due to preeclampsia. Next slide. All right, so quickly on the pathophysiology of preeclampsia, how does this disease arise, right? It is a two-stage disease, and the first stage has to do with abnormal placentation, and then this leads to the second stage, which has to do with maternal systemic endothelial dysfunction. So in normal pregnancy, the fetal trophoblasts invade the maternal uterine wall. They remodel the spiral arteries into wide, low-resistance, high-capacity vessels. But in preeclampsia, this is not the case. There is a defective trophoblastic invasion, usually in the second wave of trophoblastic invasion, and this is an incomplete or shallow process. And so these spiral arteries do not remodel the way they should. And so instead of them becoming low-resistance, high-capacity vessels, they become narrow, muscular, fibrous vessels, right? And become high-resistance vessels. And then what are the consequences of this? This will now lead to reduced uteroplacental blood flow. And we know that where blood flow is reduced, what happens next? Underperfusion happens, and then ischemia happens with the placenta. And so there is placenta hypoxia, and then there arises oxidative stress with the placenta. Now, this oxidative stress will then subsequently lead to release of amounts of anti-angiogenic factors, particularly the soluble FMS like tyrosine kinase, also what we commonly call SFLT1, and soluble endoglin, right? And these factors neutralize the activities, pro-angiogenic activities, like the vascular endothelial growth factor and placental growth factor. So this explains why I'm just trying to make the link, why you will find that the SFLT ratio in versus the SFLT PIGF or soluble tyrosine kinase over placental growth factor ratio is increased in preeclampsia. We expect that as the pregnancy progresses towards the second trimester, the placental growth factor should be increasing, but we find that in especially, and then it peaks around the 28 weeks of gestation, 28 weeks to 32 weeks of gestation. But we find that in preeclampsia, this factor begins to reduce. That is why when we do our SFLT placental growth factor marker for preeclampsia, we can find that, as a risk stratification measure for preeclampsia, we'll find that, this ratio is, disproportionately increased in women at higher risk or even women who have developed preeclampsia. So now, for the stage 2 of this pathophysiology, right? Remember I mentioned that there is now loss of proangiogenic activity, and there is why this will now lead to widespread maternal endothelial dysfunction. The damaged maternal endothelium, right? The endothelial dysfunction will cause an imbalance between mediators that are supposed to lead to vasodilatation versus mediators that are supposed to lead to vasoconstriction. E.g., prostacyclin will now be reduced. This will lead to, and then thromboxane A2 will be increased, which will lead to vasoconstriction. And so we'll have increased systemic maternal vascular resistance, which will lead to the maternal hypertension that we see in preeclampsia. We mentioned that it's a multisystemic disorder. So what will we see in the kidney? We'll see glomerular endotheliosis, where there's loss of the size and the way the whole glomerulus is arranged and all of that. And this will lead to proteinuria, protein leakage through the glomerulus of the kidneys. We'll find that there is abnormal, remember I mentioned that there is increased vascular proliferation or vascular perforation, and so you have you have fluid seeping into the third space, and you have abnormal edema, as we can see in our women with preeclampsia. There is a reduced oncotic pressure, and there is increased capillary permeability. In the brain, what will we see? We will see cerebral vasospasm, endothelial dysfunction occurs there as well. There is hyperperfusion, edema of the brain. This will lead to the headache, the visual disturbances, and all of that we see in the neurological system in preeclamptic patients. In the liver, we would have endothelial injury, ischemia, and then we will have, increased liver enzymes, and we'll have the right upper quadrant pain that we can see. Even sometimes it can lead to rupture of the Gliptins capsule, the capsule that surrounds the liver. I've talked about the hematologic changes. In the fetus, there is persistent high resistance flow. This can lead to placenta insufficiency. That is why we need to do our Dopplers for preeclamptic patients. There's fetal growth restriction. There can be oligohydramnios, and there can be preterm birth. So this is the two-stage process in our preeclampsia. Next slide, please. All right. Next slide. I've said all of this. Yes. Next slide, please. Yes. What are the risk factors for preeclampsia? So we can, basically say we have high, moderate risk factors, and then, of course, the low baseline risk factors where you don't have the high or moderate risk factors in the women, all right? And the high risk factors include amongst chronic hypertension. That's why we have to monitor our women with chronic hypertension very closely to see that they do not eventually develop preeclampsia. Chronic kidney disease, previous history of preeclampsia is a very high risk factor. We know that in obstetrics, what has happened before can happen again, right? So if she has had previous preeclampsia, then we should be looking out for it in the subsequent pregnancies. Pre-gestational or gestational diabetes, pre-gestational diabetes mellitus, antiphospholipid syndrome, assisted reproductive technology. This is some high-risk factors. Moderate risk factors include nulliparity, family history of preeclampsia, maternal age greater than 35 years, a high body mass index greater than 30 kg per meter square, multiple pregnancies, interpregnancy interval greater than 10 years. Some other, minor new findings of immunologic factors are things like, when she's married to a new husband, when she's used barrier contraceptives, some new studies are beginning to bring that up as some of the risk factors for preeclampsia as well. So women with one or more high risk factor or two or more moderate risk factors are particularly considered at risk for preeclampsia. Next slide, please. Protective factors include, smoking. That's not to say our pregnant women should go smoking because of production of hemoxidase. Repeated exposure to paternal antigen. So if she has been with the same spouse, there's a less likelihood that she would develop preeclampsia. Next slide, please. All right, so classification of preeclampsia. We can classify preeclampsia based on gestational age. where we have early onset preeclampsia or late onset preeclampsia. Now, the early onset preeclampsia is that occurs before 34 weeks of gestation. This has poorer prognosis, higher risk of maternal and perinatal morbidity and mortality. Like we know, if she comes in earlier in her pregnancy, even the management becomes a bit more difficult, especially if you are trying to, conserve management. If you have to deliver early, then you have a low birth weight baby and all of that. Right? The later onset preeclampsia, greater than 34 weeks of gestation, is more common and generally associated with better maternal and fetal outcomes, especially when we are able to intervene early as healthcare professionals. Now, this classification of based on severity versus what we used to say, mild and moderate preeclampsia or mild and severe preeclampsia, the new nomenclature is preeclampsia without severe features and preeclampsia with severe features. So we'll say that there is preeclampsia. Can you hear me? Okay. Okay, please let's mute yes. So we would say that there is preeclampsia without severe features when the blood pressure is greater than 140/90, but it is less than 160/110 millimeter mercury on 2 occasions greater than 4 hours apart after 20 weeks of gestation. And then we have proteinuria, or we have protein creatinine ratio that is elevated greater than 30 milligrams per millimoles. There's a urine dipstick of 2+ or more proteinuria, which we can commonly and availably do in our environment. Now, for preeclampsia with severe features, this has progressed to affect the organs. And so we can see a blood pressure of greater than 160/110, thrombocytopenia, where the platelets begin to drop less than 100,000, renal insufficiency evidenced by raised creatinine greater than 1.1 milligrams, per DL, or you see the creatinine beginning to double from baseline values. When we have impaired liver function evidenced by increased, AST and ALT ratios, and we see that these enzymes are beginning to double over time. We know that there is a problem there. There might be right upper quadrant pain, epigastric pain, and then in the lungs, we know that there's increased proliferation into the tissue space. We now begin to see pulmonary edema. We have new onset persistent cerebral visual symptoms, HELLP syndrome, the hemolysis, elevated liver enzymes, and low platelets that can occur. We know that this is a serious condition. Preeclampsia have progressed into severity. And of course, if they are fits, then that is at the far end of the spectrum. With the fetus, there may be severe growth restriction, and with abnormal Doppler findings, we say that preeclampsia has progressed to become preeclampsia with severe features. Another way of classification is with, associated conditions, where I've mentioned that with severe and without severe features, and then we have when preeclampsia is superimposed, where we will say you have chronic hypertension with superimposed preeclampsia, all right, and when it's complicated by eclampsia as well. Next slide. Next slide, please. Right. I've mentioned a lot of the symptoms, so I would not repeat a lot of them, but just to say, you see all the women our women coming with this persistent headache, visual disturbances, and all of that. Reduced urine output, shortness of breath, especially when there's pulmonary edema, reduced fetal movements, sudden excessive weight gain due to fluid retention. That is why I'm sure my colleague will be highlighting a lot more on that. We need to restrict fluid in our preeclamptic women so that we don't further, exacerbate the fluid overload and proliferation or movement of fluid into, the third space. Signs include hypertension, proteinuria, generalized edema, hyperreflexia, ankle clonus, and altered mental status, and the signs of pulmonary edema, like we know, tachypnea, hypoxia, and then we can hear basal crepitations as well. Next slide. All right, we have already mentioned the features, the preeclampsia with severe features that we can see. Also for the fetal features of preeclampsia, like I mentioned, there can be fetal growth restriction, oligohydramnios, abnormal Doppler findings, reduced fetal movements, and the worst, which we all do not want to see, intrauterine fetal deaths. All right, which highlights why we must monitor these women closely. Diagnostic criteria where there is new onset hypertension after 20 weeks of gestation, by that being blood pressure greater than 140/90, taken at least two occasions, at least 4 hours apart, where we have significant proteinuria, by that being either the dipstick of 2 plus or more, urine protein creatinine ratio greater than 30 milligrams per millimoles. And I just want to highlight here that if we do the urine dipstick, we are not getting positive proteinuria, preeclampsia, you can, and you're questioning, should this be preeclampsia or not, you can proceed to do the, 24-hour urine protein creatinine ratio. This helps, or the 24 hours urine collection. You can do the urine albumin creatinine ratio as well. All right, this will also help to cinch your diagnosis where you have the facilities to do so. Next slide. Next slide, please. All right. Diagnostic criteria also, when we have, as I mentioned, maternal end organ dysfunctions like the kidney injury, neurologic factors, and all of that, DIC, thrombocytopenia as well. Next slide. I just want to highlight that when we begin to see the low platelets, the platelet dropping is a very big danger sign for us as healthcare providers, where we need to act, because nobody wants DIC on their hands, right? Evidence of uterine placental dysfunction, abnormal Doppler findings can be seen. When we begin to see the absent end diastolic flow, we need to be thinking of acting immediately. I like to highlight that bit because it really helps in our management. Don't wait till, you get to where you have reversed, and before you can blink, baby is born, right? So we need to ensure that we check all of those, fetal growth restriction amongst others as well. Next slide. I think this is where my colleague comes in. Next. All right, I will hand over to Dr. Fagbemi, who will take us through, preeclampsia management, and I thank you for listening. Yeah, over to you, Dr. Fagbemi.
Yeah, thank you, Dr. Emma. Like has been said, I'm Dr. Fagbemi. I'll be taking on the management of preeclampsia. I hope everybody's hearing me. Can you hear me?
Loud and clear.
All right, good.
Yes.
So let's go. Like she said, preeclampsia, as we all know, is a progressive disease occurring after 20 weeks of gestation, and being a multi-systemic disease that affects all organs and is a progressive thing unless it's been halted. And how you put a definitive management to it is delivering the baby and delivering the placenta and the baby and the placenta, because when placenta is out, then the disease tends to resolve. So how do we manage? So the first thing you want to admit the patient, you want to see the patient and take your history in the patient and to get the history of the complications of the patient, and as well you want to do your investigations by do your confirmation of the diagnosis with the investigation you want to do, and you want to assess. Yeah. Hello.
I'm going to say you're breaking. I'm not sure if it's just from my end, but you're breaking a bit. Do you want to put off your camera to increase your bandwidth? Because you're breaking a bit. I'm not sure if it's just from me. Yeah.
Okay.
Yeah.
Can you hear me now?
Can we hear him clearly? Is it just me? You're breaking from my end.
No, I think it will help if he turns off the video.
Over to you, sir.
It's much better.
Please go ahead.
It's much better.
It's not clear.
We can hear you, sir.
We can hear you loud and clear.
Okay, you're clear. You're clear now. Thank you. Okay.
We can hear you,
sir. Is it clear from my end?
We are showing.
All right, good. So we want to confirm your diagnosis by doing the investigations, and we want to assess from the investigation, we want to assess the severity of that disease, how severe the disease has gone. I want to assess the maternal complication that has occurred, which my colleagues have earlier mentioned during his presentation. And you want to assess how good the fetus is, the fetal well-being, and you want to determine whether you should deliver the baby at that period, or you want to still proceed to allow for fetal maturation to occur, for further fetal growth. Next slide, please. So once you know your objectives, be able to tailor down to the investigations you want to do. You want to do your serum, electrolyte, urine, and creatinine, so as to know if there's any derailment. Since we all said it affects all organs, including the kidney, the liver, and also affect your blood and the blood parameters as well. So for the kidney, you want to assess how how the kidney has been affected by doing the serum erythrourea and creatinine to see the value of the erythroid that has been drained. You want to do your full blood count because in preeclampsia with severe features, those that have been complicated, you could have low platelets and the level make you start hemolyzing, and the level of the blood sometimes you could see very high because of hemo concentration and that's occurring in the patient. So, but you can also do serum uric acid where you will do you'll be able to prognosticate whether to deliver the baby at that period or not. You also want to do the liver function test where you want a factor for the pre-eclampsia, the aspartate transaminase and alanine aminotransferase with likely hydrogenase enzyme. Because of all these affectation in the liver, it raises these liver enzymes, which denotes for pre-eclampsia. So because the liver also produces coagulating factors, and this liver is being affected, the coagulating factor will be affected. So coagulating peripheral will be affected, and patient can have bleeding disorder. Because of this, you want to quickly prepare the patient for resuscitation. In case of preeclampsia with severe features, you want to do blood group and cross-matching blood ready down for the patient. So, but you could do urinary urine investigation as well, which involve the urine dipstick as you mentioned, where you're going to assess for proteinuria. And if you're able to get just 1+, which does not really significant, you should not really show significant to confirm that the patient is having preeclampsia, you can do your 24-hour protein creatinine urinary protein, 24-hour urinary protein, where you get the level of greater than equal to 300 milligram of protein in it. That shows is significant. Also, you can do your protein creatinine ratio, which also shows is significant if the value is of 0.3 milligram per milligram or 300 milligram per gram or 30 milligram per millimole. Next slide, please. So, like we said, you want to do your fetal assessment by doing a obstetric scan where to check for the parameters of the baby. You want to do Doppler studies to know whether a baby has been affected by doing the umbilical artery Doppler. Umbilical Doppler can either show, as she said, either reversed or it show absent end-diastolic flow, and that shows how compromised the baby is and determine whether you should deliver the baby or not. So, but patient, in the case where you have at the level where the preeclampsia occurs, we talked about early onset, which is less than 34 weeks of gestation, and late onset occurs after 34 weeks of gestation. If it occurs at early onset, if you do your middle cerebral artery and it's showing the middle cerebral artery is showing that the pulsatility index it falls below 5th percentile, it indicates that there's blood-brain sparing effects in the baby, which means all the blood are being channeled to the brain of the baby, the head, and that spared the head and all the other organs being affected. So it shows how severe it is. And also, you can do what is called ductus Doppler, and that will just show that there will be greater than 95 percentile as well. That showed absent or reverse flow during the antenatal during the process of investigating the fetus. And if that you're able to get greater than 95 percentile, the value shows maybe it's been compromised, and that determines level in which you're going to deliver the baby. There are some times in which you do some investigations that are not common. Only those investigations come in when you have features that show form of severity, like placenta growth factor. And the placenta growth factor is done at the early stage when you're suspecting that this patient could develop preeclampsia. And the placenta growth factor is known to be a pro-angiogenic that can prevent preeclampsia, that reduce the risk of preeclampsia. But when the value of the placenta growth factor in the blood that you assess for is low, it shows that the patient is at risk for developing preeclampsia as well. Also, when you have the case of when you do the ratio of placenta of FMS-like tyrosine kinase 1 as compared to placenta growth factor, if the FMS kinase 1 is high as compared to placenta growth factor, it shows the risk that patient could develop this preeclampsia. That shows how you can also assess for that. But in some cases where you have patients after being delivered still having some the severity of the disease, you could do chest X-ray to assess for pulmonary congestion where you could have pulmonary edema. And also, you could do ECG in the case where patient is still pregnant, though sometimes you could do chest with abdominal shield if the baby is still at the very remote age where delivery is not so good for the patient, where you could do to assess the level you are doing a resuscitation. You could also do the echocardiogram or electrocardiogram to assess the heart of the baby because this patient is at risk of having pleural effusion, pericardial effusion, and also having heart failure and things. This will be able to assess how bad the case is when you are suspecting that in case we have patient having loss of fluid into the third space. Also, in case of patient with that is unconscious because preeclampsia can cause repeated convulsion that can also lead to patient being unconscious. The glycemic still being low, and you can then be able to do your CT MRI so as to rule out stroke because these cases involve preeclampsia involves elevated blood pressure that can also bring about stroke. So the CT and MRI can be able to assess neurological deficits and be able to know whether the pathology is from the brain and not the preeclampsia itself. Next slide, please. Next slide. Okay. Now, how do we manage this patient when we have used this investigation to confirm this disease in the patient? The first thing you want to admit the patient and stabilize the patient. And you want after the stabilization of the patient, you want to now prevent further progression of that disease. Since I said it's a progressive multisystemic disorder, organ dysfunction. And also you want to prevent other complications that could occur from it. And also, because baby is inside the womb, you want to monitor the well-being of the fetus and know the state where the baby is. And you want to determine the time whether that baby should be delivered at that period based on the result of your investigation, or you still want to allow for further fetal growth. And as we all know, like I said earlier, the delivery of the placenta is only the definitive treatment. Next slide, please. So what do you do after you've admitted? You want to ensure you involve a multidisciplinary approach where you involve the senior obstetrician and you involve neonatologist to be able to manage the baby. Also, you want to involve anesthetist because the woman might be in an unconscious state that the glasgow may have deteriorated, in which you might want to, intubate the patient sometimes, or you might decide to do the cesarean section to deliver the woman, so you need an anesthetist to be involved. And also, when you have preeclampsia with these severe features, the hematologist needs to be involved so as to be able to give you blood and blood products, especially when you have what is called HELP syndrome. And also, the theater staff needs to be involved in case you're taking the patient to the theater, as well as the senior midwife when you want to deliver the patient per vagina. Also, you want to ensure that this patient airway is patent, which I said, these patients are of convulsion, and convulsion can cause secretion production, and that cause obstruction of the airway, which can further deteriorate the patient. So you want to ensure the airway is patent, ensure patient is breathing, and also ensure patient circulation is good. And this means that you're going to secure an IV access. And like I said, the being a multisystemic organ dysfunction that involves the kidney, how perfused the kidney is will be determined based on the output of the urine, and that urine comes out from production comes from the kidney. So which means ureter catheter needs to be passed to know how much urine patient is passing, which should be at least 30 mL per hour. So this baseline investigation needs to be performed. Like we all said earlier, like you mentioned, the full blood count, electrourea creatinine, clotting time, and all other investigation needs to be performed, like I as earlier said. Then you want to assess the fetal well-being as well. Then next slide, please. So we all know that this condition involves elevated blood pressure. So what we need to do after we have admitted the patient and show potential of the airway through ABC resuscitation, we want to now check the blood pressure and manage the blood pressure because blood pressure is elevated. So what we give mostly is our oral antihypertensive, which includes nifedipine, alpha methyl dopa like amlodipine. And when you give this and you're still not achieving good control, you want to involve the parenteral medications. One. Secondly, when you have blood pressure at the initial stage you are checking and it's greater than or equal to 160, and that's what is greater than or equal to 110 millimeter mercury length, you want to institute the use of parenteral antihypertensive like labetalol and hydralazine. Then you want to achieve your target blood pressure, which is what you want the patient to maintain, which will be between 130 to 139 over 80 to 89. Any range between that range is allowed for that pregnancy to maintain. Now, the seizure that we said could occur with preeclampsia, we need to prevent seizure occurring because the seizure further deteriorates the patient and cause insult to the brain, causing cerebral hypoxia, edema, and some other things to occur. So to prevent this seizure, you need to implement the use of magnesium sulfate. And I must let you know, patient that you want to use magnesium sulfate for, you must have available the antidote for magnesium sulfate, which is calcium gluconate, available in case of toxicity of sulfate, magnesium sulfate in the system. So there are different regimens we use in the use of magnesium sulfate, which include the pre-charge regimen, the Zuspan. The pre-charge regimen is the most common one we use in this country. The Zuspan, the CBI, the Code regimen, and the Dakar regimen. Next slide. This slide shows the different regimen of magnesium sulfate that we use. For example, the pre-charge regimen involves all of them involve use of loading dose, and you now maintain with maintenance dose. So for the pre-charge regimen, which I said is common, especially in my environment and also like my center, well, you're going to give 4-gram IV, and that 4-gram IV, you're going to prepare it in a different way, not that you take, because each vial comes in 10 mils, and that is 5 grams. 4 grams is going to, 4 grams will now be 8 mils. And that 8 mils is not what you're going to take and then push directly. You're going to dilute it because that the content is very, very painful and also is not too good to take as a bolus. So you're going to dilute it into like 20 mils of syringe, put the 8 mils, and add 12 mils of time to dilute it, and then give it slowly for over 5 to 10 minutes. And then you now give 10 grams into each, 5 grams into each bottle, all together making 14 grams as the loading dose. Then you continue your maintenance with 5 grams every 4 hours in alternate bottle at each time. So Zuspan is done in the case where you give it's done by giving 4 grams IV, and that 4 grams that you give for over, like the loading dose, like I said earlier, you give for over 5 to 10 minutes, and you continue with 1 to 2 grams per hour. So others are seen as written in this table, where you can take a look at it later. Like I said, when giving magnesium sulfate, you have to take note that because of its toxicity, there are some things that could be affected. So you want to ensure you are not already having the toxicity. So you want to check for respiratory rates and ensure that it is greater than 12 beats per minute. You want to ensure there is no loss of deep tendon reflex. And you want to ensure the urinary output of the patient from the catheter, because patient must have catheter in situ prior to the use of magnesium sulfate. And you want to ensure that patient is making at least 30 mils per hour of urine. And you want to ensure that the level of the therapeutic range of magnesium sulfate when you do your serum magnesium checkup. Though it's not common in this one, but we use the first level I earlier mentioned to assess when you are having toxicity. These tables show you what you can look at in case of in terms of the toxicity, where you can take a look at it later. And when you notice any form of toxicity, then you give calcium gluconate, like I said earlier, 10 mils of 10% calcium gluconate for over 10 minutes, and you monitor your vital signs in output accordingly. Next slide, please. Next slide. Okay. Now, like I said, the pre-eclampsia is a condition where you lose fluid into the top space. You're retaining fluid into the top space, and that causing edema and causing pleural effusion, some other things. Means that you should restrict the fluid that you are infusing into the patient, and which means patient should not take more than 2 liters in 24 hours. And that means you should only give 80 mils per hour. And also, you want to maintain and consistently take a close monitoring to your output of urine to know your inputs and outputs. So you chart it up. And also, like I said, with characterize the patient, that you also know that this patient, baby is inside. And most of the time, if this thing occurs less than 34 weeks, which shows early preeclampsia, lungs are not yet matured at that period. So you want to give antenatal corticosteroid for those that lungs are not yet matured. And you also want to, this corticosteroid helps you to reduce the risk of respiratory distress syndrome or transient tachypnea in the baby when the baby is born. Next slide, please. So this is the dexamethasone that you are giving. This table shows it, in which you can take a look at later. Commonly, we use dexamethasone in our regimen, in our dexamethasone regimen in our environment here, because the betamethasone is not common among in our environment. So, however, if you want to use betamethasone, it's 12 milligram you give every 12 hours, just 2 doses. And while you give dexamethasone 6 milligram IV, I mean IM, intramuscular, every 12 hours for 4 doses. And but in our environment here, what we give is 12 milligram 12 hourly, just for 24 hours. In which this, if patient the patient is well controlled, baby is okay, and it's not time for you to deliver, and baby is yet to clock 34 weeks, you can as well repeat in 2 weeks time to up to by the dexamethasone to ensure good long maturation of the baby. Next slide, please. Other things can be looked at here. So what are the advantages of the antenatal corticosteroid that you give before delivery of the baby? So this helps to reduce reduce the risk of respiratory distress syndrome that can kill the baby when baby is born. It helps to reduce intraventricular hemorrhage in the baby, because these babies are at risk because they could be born in Italy, and risk of intraventricular hemorrhage could occur. So this helps to reduce the risk of baby having that. Also, there's it also helps with to reduce the risk of necrotizing enterocolitis, and also to prevent early neonatal death from respiratory distress syndrome as well. And the need for use of respiratory support can be reduced with the use of corticosteroid. Next slide, please. So when this patient is being admitted and you're already implementing all the things you're supposed to do, what do you need to do? You need to monitor the mother and also monitor the fetus. How do you monitor the mother? You want to do your blood pressure checkup every 4 hours. And if it is more severe, you do it every 1 to 2 hours. However, symptoms like from premonitory signs like headache, visual disturbance, and upper gastric pain need to be watched out for, so as to know that the patient, the disease is progressing to the severe state, so that you can deliver the patient before it compromises before it affects the life of the mother. Because the loss of mother means the loss of the baby if perinatal cells is not done on time. But these signs show patient is becoming more severe from the disease. Also, neurological assessment needs to be done. Neurological assessment needs to be done to check level of the consciousness, whether it's improving in the patient, and also check for reflexes as well, and know the deficit in this patient neural system. Also, you want to do, like I said earlier, we check your fluid balance and ensure that you have adequate output of urine output, which will be at least greater than or equal to 30 mL per hour. And also, you want to monitor the magnesium toxicity during your magnesium sulfate use. You want to ensure the patient does not have any toxicity, which can kill the patient. So for the fetal monitoring, you want to ensure the daily fetal movement assessment by doing what is called fetal kick charts, by giving it to the mother to just so I can assess whether to intervene or not if you're having a reduced fetal movements at any point in time. Then you want to do your CTG to check for deceleration, which shows fetal being compromised. You want to do your ultrasound scan every 2 to 4 hours, 2 to 4 weeks rather, so as to assess for fetal growth, or you're having growth restriction in the baby. And if growth restriction is occurring in the baby, that could point to you having some parameters being affected, like amniotic fluid, which shows there's head sparing effect. Blood being shunt off away from the kidneys and other organs and being sparing the brain, and that's reduced perfusion to the kidney and reduced output of urine in the baby, which reduces the amniotic fluid volume. And that shows a sign for you to do appropriate intervention. Also, you can do umbilical Doppler like I said earlier, to assess how compromised the fetus is, and you do biopsy profile, especially when the baby has gotten to about 30 weeks of age, because at 30 weeks gestation is where you have the autonomic nervous system being developed. How do you now, what do you do based on your, after you've assessed the patient and everything is in place? If everything is fine, you can allow the patient to get to 37 weeks and above, and you do your delivery. And the recommended delivery for stage or gestation that you can do for the woman is after 37 weeks, which is when everything is in place. However, when you have any fetal condition or maternal condition, you can deliver the woman between 34 to 30 weeks, especially when you have late onset and deliver within this period. And but when you have early onset of preeclampsia and you have no choice to deliver, you need the patient having early onset of preeclampsia and you want to deliver and you have measured the blood pressure is controlled, the maternal condition is stable, fetal surveillance, you have to ensure that you have patient being okay and the baby being okay. And early onset at that period, if anything being compromised within this period, you need to deliver. But if not being compromised, you can push the baby to have another development in the baby so as to have allow good fetal maturation. And then especially when you have the availability of you have availability for neonatal care, which will help the baby even if being born in neonatal, you can deliver less than 4 weeks. Next slide, please. So there are some conditions in which you need to deliver the woman immediately. What are these conditions? When you have given all management, you've thrown all your mercenaries, and you're still having the severe hypertension being severe, is not controlled. Patient is not having repeated seizures despite you're using magnesium sulfate, and you have what is called hemolysis and low platelets that can cause may cause DIC in this patient. When all these are in place and patient having pulmonary edema is not causing respiratory distress, or this condition has made the patient to have all these complications like renal failure as well, and your cause of the elevated blood pressure, it has abrupted the placenta and causing placenta abruptly to patient to bleed inside. And also, when you have the severity of the symptoms is not becoming persistent, and you have, just like I said, all these need immediate delivery to avoid any sudden death in the mother. Also, in the condition where you do immediately for the baby, you need to have, when you do your cardiograph CTG, which will show you non-reassuring fetal status, and also when you have fetal growth restriction that is further deteriorating, or when you have the condition where you have absent or reverse endoscopic flow after doing your umbilical artery Doppler. And all these are signs that shows baby is being compromised. And if before you close your eyes, baby can die. So you need to deliver this baby. And also in the condition, of course, when you have intrauterine fetal death. So when you want to deliver this baby, it should be in the fastest and the safest way. However, we all know the best way to deliver is through vagina when you have no obstetric complication. But you must put at the back of your mind that before you can achieve vaginal delivery, the service of the woman must be favorable and the maternal condition is at bay. The woman cannot be presented with preeclampsia that you want to manage and you want to deliver, already having 8 centimeters cervical dilatation, and you say you want to go and do cesarean section. She's already almost fully dilated. You can allow her to dilate and then do second stage assistance to deliver the fetus, so as to shorten the second stage for the woman. However, you need to do cesarean section in a condition where you have where the service is unfavorable and there's no obstetric complication into the delivery using the vaginal delivery. Next slide, please. Following delivery of the woman, you need to continue your magnesium sulfate for another 24 hours post-delivery or after the last seizure the woman had. And you continue to monitor the blood pressure of the woman. And then you continue to institute the use of antihypertensive therapy as required based on the value you are getting, because placenta is out, the condition may now be resolving gradually. So that determines the dose of the antihypertensive you're going to use. And also, you're going to do your kidney and the liver function test to assess the recovery of these organs, because that's the reason why you need the baseline investigation be able to now assess whether it's already going down. However, you need to now do your counseling for this patient. Counsel this patient on the risk that this disease, sometimes you could progress to have cardiovascular disease later in life, because some people may not, even after delivery of the placenta, some do not have resolution in this elevated blood pressure, and some do not have a relation with the cardiovascular disease that are occurred. So you need to counsel them to continue further station for management and to see their cardiologist for that. Next slide. Now we've talked about preeclampsia. Preeclampsia, as we all know, it can lead to death. One of the maternal mortality, condition called maternal mortality. How do we prevent it? So in prevention, we have primary prevention, secondary prevention, and the tertiary prevention. Like I said, before you can develop preeclampsia, there are some that will have the risk, and there are some that will have the risk before getting pregnant, and there are some that will have the risk and still got pregnant, and there are some that will now develop it afterwards. So the primary prevention is talking about those they are not pregnant yet, but they have the risk of developing preeclampsia because they have all those maternal indicators, like we mentioned the chronic hypertension, chronic disease, diabetes, those that have done IVF, multiparity, like my colleague mentioned them all the time when she was presenting. So these are the people, after you have taken history in them and you have seen that they have the risk, you want to do what is called preconceptional care for them and ensure that these things that they have has been taken care of. And it which will now reduce the risk of developing preeclampsia in them. Example, like those that have elevated body, that have obesity, need to reduce the weight. Those that have low calcium intake need to have calcium intake, calcium supplementation in their diet to ensure that they will not develop preeclampsia when they get pregnant. Next slide. Secondary prevention talks about those that, despite we've told them they are not, they've not done what they're supposed to do, but they got pregnant before presenting to you and they have the risk. So which means they've not developed preeclampsia, but they have the risk of that they'll develop preeclampsia because they're already pregnant. You cannot do preconceptional care for them anymore. So these are the ones we do secondary prevention for by doing risk assessment, by checking for those that moderate risk and high risk. My colleague talked about the risk factors then, and those that have high risk, one high risk or more, you are going to give them what is called low dose aspirin. Low dose aspirin, or you give them, or you can give them calcium supplementation for those that have low calcium intake in their body after doing serum calcium, and you monitor them. You do antenatal surveillance for them by reducing the week devastation. Those that are supposed to come every 4 weeks should be reduced to 2 weeks. Those that are supposed to come every 2 weeks should be reduced to every week. So this helps you to reduce the risk of them developing preeclampsia because they have the risk before and they're already pregnant. So when you give this, it helps to prevent it. Next slide, please. So how do you now screen those that have that you are thinking that, okay, this one belongs to secondary clients that you want to do secondary prevention for them. They're already pregnant and they have the risk of doing preeclampsia because of their features. So you want to do what is called blood pressure monitoring at the early stage. In this blood pressure, you want to check whether they already have elevated blood pressure. You want to do the urinalysis because they're already pregnant. You want to do urinalysis and check for proteinuria. You want to do what is called screening tests for them. Those screening tests, you issues of what is called maternal factors, like the risk factors my colleague mentioned. And you want to do what is called mean arterial pressure. The mean arterial pressure means you want to calculate, assuming you have done a blood pressure for a patient, the calculation for the mean arterial pressure in the patient means that you do add the diastolic blood pressure to 1/3 of the systolic minus diastolic, which means you're going to get your whatever systolic you get, you monitor, minus the diastolic from it, divide it by 3, and then add it to the diastolic blood pressure. Or you take your systolic diastolic blood pressure, multiply it by 2, and add it to the systolic blood pressure and divide it by 3. If you got a value that is greater than 90, that's greater than 90 millimeter mercury length, it shows the patient is at risk of pre-eclampsia. You can also do, to prevent at this stage, you can also do what is called uterine antidoppler, which is done between 11 to 13, between 11 to 13 weeks plus 6 days. And this will show you you see the notch, and that's how the Doppler will show you that this you have loss of second wave variation that can even affect and cause preeclampsia. And the biochemical markers you can do when you take the patient blood markers is to do placenta pregnancy system plasma protein A and the placenta growth factor. These two biochemical markers, they help prevent preeclampsia. But in the condition where a woman will develop preeclampsia later, the value of this PAPA and the PIGF, placenta growth factor, their value will be low, which will not make the other ones that can predispose you to preeclampsia to be high, which is the soluble endocrine and the placenta and the FMS like tyrosine kinase. Next slide, please. This table talks about what I just discussed now, where we talk about the maternal factor when patient presents and the secondary, I want to prevent the patient to see patient is pregnant and also having high risk. We want to assess the value, whether the age of patient greater than 35, BMI, whether greater than 30, multiparity, and this shows patient is at risk already. Then you go ahead and do the blood pressure, and then you calculate the mean arterial pressure. If it's greater than 90, it shows patient at risk of preeclampsia. And also, you do a uterine artery Doppler, where you see the diastolic notch and the present diastolic notch, and also the pulsatility index will also be high. And this shows patient will develop preeclampsia. Also, when you do your first algorithm that I talked about, it shows patient will develop preeclampsia. All this will not be put into the algorithm, and the value you get if the greater than 1 in 100, it shows patient is high risk, and if less than 100, it shows patient is low risk. If patient is low risk, you just do your normal routine center care and standard monitoring to watch out for anybody with high risk. You need to implement the use of medications that can use to prevent it by giving low dose aspirin. Next slide, please. So tertiary talks about those that are pregnant, have high risk, pregnant, and have developed pre-eclampsia. So once preeclampsia has been developed, the first thing you want to confirm your diagnosis, like you said earlier, doing investigation and assess for the severity, like I talked about before. You do your fetal surveillance, you implement the management of antihypertensive, you give magnesium sulfate, mature the lung with corticosteroid, and you determine when to deliver the woman, and you do your postnatal care. Next slide. So like I said, most women after management, after delivery of the placenta, they recover within days to weeks after the delivery. And you know the definitive treatment, which when you deliver the placenta and the baby is out, the conditions start resolving. So what about the women after you have delivered them? There are some women that have lifetime risk, future lifetime risk. Those that have chronic hypertension, which means they develop the hypertension prior to getting pregnant. Those that have cardiovascular disease, like heart disease, stroke, or kidney disease, those ones will develop lifetime risk as well. Those with chronic kidney disease have lifetime risk that they continue to have, you understand. And those that have history of pre-eclampsia, they would definitely have is a high risk for developing preeclampsia in the future pregnancies as well. And when you now have it recurrence, or the percentage of you having it when you've had it before is 15%, but if it occurs less than 34 weeks, or you have it being more severe, risk of recurrence becomes more higher in you. Next slide, please. So what are the prognoses that you could have? Now, in the baby, the prognosis depends on the severity of the placenta insufficiency. That we said earlier, that placenta is one that takes the blood flow to the baby, and this it's affecting the flow of blood. Preeclampsia affects flow of oxygen to that baby, and that can compromise the baby, which will now reduce nutrition, oxidation to baby, and that causes insufficiency in the growth of the baby due to the blood that is being affected. And this prognosis in this kind of baby is prognosis is of the fetal death is very high if this condition occur. But the prognosis of when after being baby have been delivered determine when the baby is being born. A baby that is being born at the early gestation, maybe around 28, 29 weeks, shows needs for use of for intensive care unit, neonatal intensive care unit, in which the facilities available in our environment are not so superb, and that leads to bad prognosis for this patient, for this baby being delivered. Also, if you make use of antenatal corticosteroid prior to delivery of this baby, especially when they occur in the early stage, prior to 34 weeks of gestation, it improves the prognosis and outcome of the baby after being born as a premature or after being born as a premature. Then the factors that talks about the prognosis mostly and early make it so poor. Like I said, if the onset of preeclampsia occur at less than 34 weeks, which is early preeclampsia, especially when you even have severe hypertension and there is complication in the mother like Hep syndrome, patient having repeated seizure, all this further compromise the baby. And also when women have renal pathology that comes on because you reduce flow to the baby cause reduce blood flow to the organs, and that affects it.
Hi,
So,
Dr. Fagbemi. Sorry, please,
yeah,
you have just about 2 minutes left.
no
Thank
problem.
you.
Next slide. Next slide. That's the slide before this, right? Okay, this has talked about everything that I've mentioned. And in the pipeline now, there's something we've talked about all this in the figure 1, 2, 3, 4, 5, 6, and the 7. But there's something emerging for prevention that we talked about, which includes the use of statin that is being invested, but it's not for clinical use right now. It's still in the process. And also plasma the pheresis that want to be done by reducing reducing taking blood from the woman to reduce the placenta, the factors that could cause preeclampsia in the patient, like tyrosine kinase and FSL tyrosine kinase and sulfendoglin, so as to reduce when you take the blood. Also, lifestyle modification needs to also the target imagine thing that's been done is targeting the vascular drug that can be given to the patient is being used for production now, and then the antioxidant that will be produced also all in the pipeline now, but not yet out. Next slide. These are my references. Thank you.
Thank you. Thank you so much, Dr. Fagbemi and Dr. Aima, for this enlightening session. If we can get more hands and rounds of applause from reactions from the audience. Thank you so much. I have learned a thing or two, and I believe the people who have joined have also learned a thing or two. Dr. Fagbemi, if you don't mind, we would like to see your face just in case we run into you somewhere on the streets of Lagos so that we can know that it's you. All right. So quickly, we know that time is fast spent. Quickly, we would just like to have a case presentation to bring all this to life, all the presentation, diagnosis, and management, just to see how it plays out in a real scenario. So Dr. Peace Romosela is going to help go through that case presentation as we just see how preeclampsia presents in real life and how it is managed. We've taken note of your questions, and after the case presentation, we would attend to the questions. And if you have more questions, just keep it coming in the chats. Thank you so much. Over to Dr. Peace. Thank you. Dr. Peace, you're muted if you're speaking.
Oh, okay, I couldn't unmute at first. Good evening, everyone. So I'm briefly going to go through a case presentation of a member with pre-eclampsia, and we're just going to see how the patient presented and the intervention that was given. So for the patient's biodata, the patient is patient AE, 29-year-old female, married, Yoruba, of the Christian religion. She's a secondary school teacher with tertiary level education, gravid 2 para 1 plus 0 with 1 alive. Last menstrual period was 2nd of November with the EDD 9th of August 2026. So as at presentation, she had a gestational age of 38 weeks and 2 days. Next slide, please. Yes, so she presented with a okay. I couldn't see the screen for a second. She presented with a severe frontal headache of a 2-day duration prior to presentation, blurring of vision for 12 hours, swelling of both the feet and face for a week prior, and reduced fetal movements, for which she noticed 18 hours before she presented. Next slide. Yes, so the patient was well until 2 days prior to presentation when she developed a persistent severe frontal headache not relieved by analgesics, which in this case was paracetamol. So 12 hours prior, she noticed blurring of vision with flashing lights and worsening swelling of the lower limbs and her face. She did not have vaginal bleeding, leakage of liquor, fever, or convulsions, but she noticed reduced fetal movements 18 hours prior to presentation. And so, on account of the listed symptoms, she measured her blood pressure at a nearby pharmacy on the morning of presentation at the hospital, and it was 174 over 112, which prompted her presentation at the hospital. So the pregnancy had been uncomplicated until about 34 weeks when she started noticing elevated blood pressure readings, which were noted during her previous antenatal visits. She was placed on antihypertensive medications, in this case, methyl dopa, 500 milligrams twice a day, but she admitted to missing doses over the preceding week. So she was not adherent to her medication. So for the previous medical history, there was nothing particularly of note. She was not a known patient with hypertension or diabetes, no history of renal disease. Her blood group was O positive, genotype AA, no previous surgeries or transfusions. Her first pregnancy was uneventful. Next slide, please. So for the index pregnancy, she was booked for antenatal care at 14 weeks. She attended 7 antenatal visits. She received tetanus toxoid vaccine, iron and folic acid supplementation, malaria prophylaxis, routine ultrasound scans as expected, and she had no previous diagnosis as I've said before, until the no previous diagnosis of hypertension until the late 3rd trimester. For her gynecological history, she attained menarche at 13 years with a regular cycle, no history of dysmenorrhea or menorrhagia. She had a history of injectable contraceptive for 2 years prior to conceiving. So she had never done a pap smear. There was no known allergy or food allergy. So for family and social history, she lives with her husband and a child in Lagos. She does not smoke or consume alcohol. She does not use recreational drugs. She has a family history of hypertension, but no family history of diabetes or kidney disease. So for the general examination, as stated before, her blood pressure was markedly elevated. That's at 176 over 114 millimeters of mercury. Her pulse was 96 beats per minute, respiratory rate 22 breaths per minute, temperature 36.8 degrees Celsius, SpO2 98% in room air. Physical examination revealed moderate facial puffiness, bilateral pitting, pedal edema up to the knees. So it was significant. There was no pallor or jaundice. No S1 and S2 heard on cardiovascular examination. There were no basal crepitations on respiratory examination. For the abdominal and obstetric examination, fundal height was 37 centimeters. There were no contractions. Singleton fetus noted to be in cephalic presentation and longitudinal lie. Fetal heart rate was 105 beats per minute, and there was no tenderness as at the time of examination. No uterine tenderness. So the as said before, there were no contractions and the cervix was closed when she presented. CNS examination revealed hyperreflexia and sustained ankle clonus. So the diagnosis made was preeclampsia with severe features at 38 weeks and 2 days gestational age. So the initial management that was carried out was the patient was admitted, and senior obstetrician and anesthetist informed, IV access secured with 2 white ball cannulas, Foley catheter inserted for strict urine output monitoring, and fluid restriction commenced. Next slide, please. So these were the tests that were carried out and what was discovered. So for her urinalysis, there was a proteinuria of 3 pluses, full blood count revealed hemoglobin of 11.2 grams per dl, platelets of 92, urea and electrolytes were within normal limits, creatinine as well, AST and ALT were within limits. LDH was elevated. Clotting profile was normal. Blood group and cross match was made, and an obstetric ultrasound showed a singleton fetus cephalic amniotic fluid index of 7 cm. Absent end diastolic flow was noted on the umbilical artery Doppler. CTG showed persistent fetal bradycardia with reduced variability. So for the management, magnesium sulfate was administered using the Pritchard regimen for seizure prophylaxis. IV hydralazine was administered. She was also given oral nifedipine, and continuous maternal and fetal monitoring was carried out. So for definitive management, as was stated earlier, the definitive management here is delivery of the placenta. So an emergency lower segment cesarean section was carried out for this patient. So the outcome of the delivery was a live female neonate delivered, birth weight 2.7 kilograms, ABGA scores 7 at 1, 9 at 5 minutes. Estimated blood loss was 650 milliliters. Mother was stable. Magnesium sulfate was continued for 24 hours post delivery. blood pressure gradually improved on the medication she was given, and the mother and baby were discharged home on post-op day 5 with follow-up in the postnatal hypertension clinic. So 2 weeks after delivery, at her postnatal review, her blood pressure had reduced considerably and was at 132/84 milliliters of mercury. Urinalysis had no abnormalities seen. Headache had resolved. There were no visual symptoms. Surgical wound had healed. The baby was doing well, and she was counseled on the risk of recurrence for future pregnancies. So she was counseled on the recurrence risk, importance of booking for antenatal visits early, and low dose aspirin prophylaxis.
Yeah, thank you
Okay,
so much,
thank
Dr.
you.
Peace. Thank you so much, Dr. Peace. It's really beautiful to see how the lecture that we received came alive in this patient who you have presented, and I'm happy, even though I don't know her. I'm happy that she made good recovery and mother and baby came out alive. Please let's appreciate Dr. Peace for taking us through the case presentation. As we move very swiftly into the question and answer session, we have just 10 minutes for this because time is fast spent. And I would just start with some of the questions that have been in the chat while the presenters were presenting. So the first question that we got was, what are the signs of magnesium toxicity? And the second question was around the same magnesium toxicity that says, how long should magnesium sulfate be continued after delivery? So I'll just allow Dr. Fagbemi to take these two questions together. What are the signs of magnesium toxicity and how long should it be continued after delivery? I know you touched on it during your presentation, but I'll just allow us here from the horse's mouth. Dr. Fagbemi, over to you if you can hear me. Or Dr. Ima.
Okay. Yes, great. So signs of magnesium sulfate toxicity, we say you can have toxicity that becomes evident in several ways. Have neurologic, it shows in the neurologic system, in the respiratory system, and the cardiac system as well. And in that order, usually progresses as the level in the system continues to increase. Now, for neurologic toxicity, I hope I'm for the neurologic toxicity,
You are.
when the magnesium sulfate is as high as 9 to 12 milligrams per DL in the system, we begin to see that. And you may observe deep tendon reflexes, lots of deep tendon reflexes, hyper or hyporeflexia. You might see all of those in the patient, just patient having slurry speech, just not as coherent as they used to be. Now, for respiratory depression, we have it at usually higher levels of magnesium sulfate in the system. Some studies will say 12 to 18 milligrams per DL. Some will say about 10 to 15, when you have about 10 milligrams per DL to 15 milligrams per DL in the system. And, for the respiratory one, you have respiratory depression. You will notice the respiratory rate begins to drop, right? Less than 12 cycles per minute. The breath sounds are not as they would normally be. You begin to, worry that you might be having that. Cardiac toxicity, some will say greater than 18 milligrams per DL. Some will say greater than or equal to 25 milligrams per DL. And then you can have bradycardia in the patient and in some cardiac arrest. So cardiac toxicity occurs at, usually higher levels of magnesium sulfate in the system. And that's why my colleague highlighted that, you should have calcium gluconate on ground as one of our emergency drugs in our emergency cart as obstetricians or as doctors. And then you should be ready to give calcium gluconate 10% of 10 meals over 10 minutes. So we don't forget that 10-10-10 rule. Even if you don't remember anything, just remember the 10-10-10. You know what to do when it occurs, and then you need to continue to track that patient. You can do serum magnesium levels. You can, also monitor the urine, and you can do electrolyte urea creatinine levels as well, when you suspect a patient is having this. And don't forget to stop the immediately. I think the other question was, how long do you give a magnesium sulfate for? As he highlighted, you give it till 24 hours after delivery or after the last fit, whichever comes last. All right, thank you.
Thank you so much, Dr. Aima. Can we get a round of applause from people in the chats? Thank you so much. Dr. Aima, you're breaking up a bit now, but I thank you so much for doing justice to that question, and I hope that the person who asked it has gotten the clarification that they needed. So the next question was that what are the chances for someone who has hypertensive disorder to develop pre-eclampsia, I believe, and eclampsia, and can this be mitigated? So I think I would pass the mic to Dr. Fabemi to answer this one. What are the chances for someone who has a hypertensive disorder to develop pre-eclampsia and eclampsia, and can this be mitigated? Okay, so I'll unmute you. Sorry, I can see that you're speaking on mute. Can someone help me unmute Dr. Fagbemi, please?
Thank God.
All right. Yeah, sorry about that. Sorry about that, sir.
The question again, sorry.
So yeah, someone wanted to know the chance of someone who has chronic hypertension. They call it hypertensive disorder. What are the chances of such a person developing pre-eclampsia and eventually eclampsia, and how can this be mitigated?
Now, especially a patient that has developed pre-eclampsia before, with prior history, has a higher risk of developing preeclampsia, like I said, 15 to 20%. When this patient have a recurrence, the risk of developing chronic hypertension and cardiovascular disease in the patient becomes higher later in life because you have a repeated repeated condition of that particular disease, which will prone you because which shows you've had insult to the organs causing compromise of the disease several times. So that prone that kind of patient to having facial cardiovascular disease. Any other question?
All right. So I thank you so much for that answer. So I think I'll just allow the audience, if you want to unmute and ask your question. I mean, there are some other questions in the chat, but it will be really nice to hear the voices of the people on the meeting. So if you have any question, please hand, you'll be unmuted and you can ask a question. Anyone? Because
Hello.
all right, so okay. Is someone trying to ask a question?
Audible?
Please go ahead. Yes, we can hear you. Just tell us your name, where you're calling from, and then you go ahead with your question.
Thank you. I dropped. Thank you. I'm sorry. I'm calling from
Okay.
Abuja.
Excellent.
Oh, my network is poor.
We can hear you. Go ahead.
I dropped a question in the chat box, but it wasn't asked.
Yeah, we just
You
wanted to
can
hear
see it. What was your question?
We just wanted to hear your voice. Yeah, go ahead and ask the
Okay.
question.
How long? Okay. You see a patient and make a diagnosis of preeclampsia,
Yeah.
and she's remote from term. So you're trying to manage her conservatively. You've given magnesium sulfate as is required. And now blood pressure is controlled. You want to push to get at least to the age of viability or a little bit beyond for fetal lung maturity. So how long do you keep giving a magnesium sulfate for before you exit that pregnancy?
That's
Now,
That's an
Magnesium,
excellent question.
yeah,
Yeah, please go ahead, Ogbemi.
like I said, you are not giving magnesium sulfate magnesium sulfate is only given when you are planning to deliver the woman in the next 24 hours. One. Two, except sometimes you might just want to give a neuroprotective dose, so as to protect the brain of the baby. If you are giving magnesium sulfate, you have already started. When you are managing, okay, now you have a patient with preeclampsia from remote, and like I said, you've given antihypertensive to control. You're giving your corticosteroid. The prevention of convulsion in the patient determines what presentation the patient brought to your table. You are not seeing this patient progressing to any form of severity. You have admitted this patient, you have done an investigation, you have confirmed preeclampsia, but you have not getting any form of severity in this patient. No features of severity from the organs investigation you have done. ESR is normal, LFT is normal, the clotting profile is normal. You are not getting any form of severity in this patient. So you are not trying to see a way that you want to do prevention of convulsion in this patient, because this patient is to be given antihypertensive as well, and blood pressure is controlled. You can allow this baby to have more maturity while you are doing your intensive fetal surveillance. Because magnesium sulfate is not something you continue for a longer period of time. Like I said, when you give it, you are going to deliver the woman within the next 24 hours, except that you gave only neuroprotective dose. And after 24 hours, you're going to give it for you're delivering the woman in 24 hours, and you continue to give magnesium sulfate till 24 hours post your delivery or last ICTA. Outside this box is not a drug that you continue to give because of its toxicity in the body, and it needs to be monitored. Do you understand?
Thank you so much, Dr. Fagbemi. Thank you so much for Dr. Fagbemi for that excellent answer to the question. I can see one more hand, so I would you can go ahead and unmute Miss or Mrs. Stella. So we can take one more question from you, and then we'll take some others in the chat. Mrs. Stella, do you still want to ask your question? Okay, while she's trying to unmute, there's another question in the chat that was on postpartum preeclampsia, and I think whoever asked this question was paying very rapt attention, because you mentioned that preeclampsia is caused by the placenta. It's primarily a disease of the placenta. And then someone wants to know, there's such a thing as postpartum preeclampsia, and at that point, the placenta has already been delivered. So what exactly is causing the preeclampsia in the postpartum preeclampsia setting? So please, you can go ahead and answer. Thank you, sir.
All right. In this condition, we mentioned one thing, that like we said, give magnesium sulfate 24 hours post delivery or last ICTA. Reason being that the component that has caused these condition to be in the body, FM-like tyrosine kinase is high, the soluble endoglin is high, and the plasma growth factor and papa are low. This thing does not go out of the body immediately like that. That is why we talked about puerperal stage, which takes up to 6 weeks. So you continue to monitor this patient for up to 6 weeks post-delivery. All those that do not resolve within the 6 weeks period are those that are at risk of having the future cardiovascular diseases.
All right. Thank you so much. Thank you so much.